Welcome back to RXology. So, we got the ACE inhibitors covered last time, but for the significant number of patients that can't take them, we're now going to talk about angiotensin receptor blockers. ARBs share nearly all the same indications as ACE inhibitors like hypertension and heart failure, but they work fundamentally different within the RAAS pathway, and that's what we're going to deep dive into. ARBs are the drugs that end in sartan, like Losartan and Valsartan. You get it. Let's crush some board questions. If you have not watched the ACE inhibitors episode, I strongly recommend it first, as we walked through the entire RAAS pathway step by step. It's linked in the description. Here's a lightning-fast refresher. When the kidneys detect low perfusion, the juxtaglomerular cells release renin. Renin converts angiotensinogen from the liver into angiotensin 1. Angiotensin 1 is then converted by angiotensin-converting enzyme, our friend ACE, into angiotensin 2, the most potent vasoconstrictor produced by the body. Angiotensin 2 binds to angiotensin 2 type 1 receptors, called AT1 receptors, which are located on blood vessels, the adrenal cortex, and the kidneys. The end result is vasoconstriction, aldosterone and antidiuretic hormone release, sodium and water retention, and increased sympathetic activity. All of that will end up raising blood pressure. When a patient is on an ARB, the body can still produce angiotensin 2, but the drug will block the AT1 receptor, so angiotensin 2 cannot actually bind and exert its effects. By blocking the AT1 receptor, ARBs result in vasodilation, decreased aldosterone so the kidneys can excrete more sodium and water, and reduced efferent arteriolar constriction in the kidney. This is why ARBs, like ACE inhibitors, are renoprotective, super beneficial in diabetic nephropathy. No bradykinin accumulation is the single most important distinction between these two classes, and it is tested constantly. Remember from the ACE inhibitors episode, ACE does two jobs. It converts angiotensin 1 to angiotensin 2, and it degrades bradykinin. ACE inhibitors block both of those functions, so bradykinin accumulates. That elevated bradykinin is directly responsible for the dry cough and the angioedema. ARBs do not bother ACE. Because they work downstream on the receptor site, they do not affect bradykinin metabolism, so ARBs have a significantly lower incidence of cough and angioedema compared to ACE inhibitors. This is the number one reason patients are switched from an ACE inhibitor to an ARB, and it is one of the most commonly tested concepts on board exams. When you understand the mechanism, you understand the side effects. Because ARBs block angiotensin 2 at the receptor level, their RAAS-related side effects are the same as ACE inhibitors. You just have to remember what they don't cause. The side effects that are the same include hypotension. You are reducing vasoconstriction and blood volume simultaneously. First-dose hypotension can occur, particularly in volume-depleted patients or those already on diuretics. A clinical pearl, you want to start low, go slow. Hyperkalemia. ARBs reduce potassium excretion by suppressing aldosterone. This can cause a buildup of potassium. Monitor potassium levels, especially in patients with chronic kidney disease or those taking potassium-sparing diuretics like spironolactone. Acute kidney injury. ARBs dilate the efferent arteriole, decreasing glomerular filtration pressure. In patients with bilateral renal artery stenosis or severe volume depletion, this can cause a dangerous drop in GFR. A rise in serum creatinine of up to 30% from baseline is acceptable. Greater than 30%, stop the drug and investigate. The key difference between ACE inhibitors and ARBs is which side effects ARBs do not cause. There is no dry cough. Because ARBs do not affect bradykinin metabolism, the incidence of cough is essentially the same as placebo. Angioedema is rare with ARBs, but not zero. The cross-reactivity rate between ACE inhibitor-induced angioedema and ARBs is low, and current guidelines allow cautious use of an ARB in patients with a history of ACE inhibitor angioedema. However, if a patient develops angioedema on an ARB, discontinue immediately and do not rechallenge. The black box warning for teratogenicity is the same as ACE inhibitors, and it is to be avoided in pregnant patients. We just discussed pregnancy as a contraindication. The other contraindications are a reiteration of the side effects, such as patients with bilateral renal artery stenosis and hyperkalemia. A beloved drug interaction on the boards is the triple whammy combination of an ARB plus a diuretic plus an NSAID. You have to be able to recite this in your sleep. This combination significantly increases the risk of acute kidney injury and hyperkalemia because NSAIDs reduce renal prostaglandin-mediated blood flow, while the ARB and diuretic are already decreasing glomerular filtration pressure and volume. If a board question presents a patient on an ARB and diuretic who starts ibuprofen and develops a rise in creatinine, the NSAID is the culprit to discontinue. Another important point is to avoid double RAAS blockade. It can only cause harm with no additional cardiovascular benefit. The same way you would not combine ACE inhibitors with ARBs, the FDA warns not to combine with the drug aliskiren, which is a direct renin inhibitor. It works upstream of ACE inhibitors in the pathway and can lead to hypotension, hyperkalemia, and acute kidney injury as well. Losartan was the first ARB approved for clinical use and remains one of the most commonly prescribed. It is FDA approved for hypertension, type 2 diabetic nephropathy, and stroke risk reduction in patients with hypertension and left ventricular hypertrophy. Losartan is a prodrug. It is metabolized by CYP2C9 and CYP3A4 to an active metabolite which is 10 to 20 times more potent than the parent drug. Because it is a prodrug, be aware that CYP2C9 inhibitors like fluconazole can reduce the conversion to the active metabolite and potentially decrease efficacy. What makes Losartan unique among all ARBs is its uricosuric effect. Losartan inhibits the urate transporter URAT1 in the proximal renal tubule, which promotes uric acid excretion and lowers serum uric acid levels. No other ARB does this. This makes Losartan a particularly useful choice in hypertensive patients who also have gout or hyperuricemia, especially since thiazide diuretics, commonly used for hypertension, actually raise uric acid levels. Losartan has a relatively shorter half-life compared to other ARBs, so some patients may require twice-daily dosing for full 24-hour blood pressure control. Valsartan is FDA approved for hypertension, heart failure, and post-MI care in patients with left ventricular dysfunction. It is not a prodrug and does not require hepatic activation. The key point for the boards about Valsartan is that it's the ARB component inside the combination drug sacubitril/valsartan, or Entresto, the landmark neprilysin inhibitor combination used in heart failure with reduced ejection fraction. Since Entresto already contains an ARB, no additional ARB or ACE inhibitor need be added in guideline-directed treatment of heart failure. Telmisartan is FDA approved for hypertension and for reduction of cardiovascular risk in patients unable to take ACE inhibitors. It has the longest half-life of any ARB at approximately 24 hours, providing true 24-hour blood pressure coverage with once-daily dosing. It is highly lipophilic with extensive tissue distribution. What makes Telmisartan unique is its partial agonist activity at PPAR-gamma, peroxisome proliferator activated receptor gamma. PPAR-gamma is the same nuclear receptor targeted by the thiazolidindiones like pioglitazone used in type 2 diabetes. No other ARB activates PPAR-gamma at clinically achievable concentrations. While this property has not translated into a clear diabetes prevention advantage in large trials, it is a frequently tested board concept. Telmisartan has been shown to be non-inferior to ramipril for cardiovascular risk reduction, making it the evidence-based ARB alternative when a high-risk cardiovascular patient cannot tolerate an ACE inhibitor. Olmesartan is FDA approved for hypertension. It is a prodrug hydrolyzed to its active form during absorption. It has a long half-life of 12 to 18 hours for once-daily dosing. The unique clinical concern with Olmesartan is sprue-like enteropathy. This is a rare but important side effect where patients develop severe chronic diarrhea with villous atrophy of the small intestine, mimicking celiac disease. Symptoms can develop months to years after starting the drug and resolve after discontinuation. If a board question describes a patient on an ARB with chronic diarrhea and weight loss, think Olmesartan. This side effect has not been consistently observed with other ARBs. Let's review what is most likely to get tested. 1. ARBs are the go-to alternative for ACE inhibitor-induced cough. 2. Monitor potassium and creatinine. Check a baseline metabolic panel before starting, recheck in 1 to 2 weeks, and with every dose increase. Creatinine rise greater than 30%, stop and investigate. 3. ARBs are contraindicated in pregnancy. Labetalol or nifedipine are the safe alternatives. 4. Bilateral renal artery stenosis plus ARB equals acute kidney injury. Same trap as ACE inhibitors. 5. Do not combine ACE inhibitors with ARBs. Dual RAAS blockade increases renal harm without improving outcomes. 6. Losartan is the only ARB with a uricosuric effect. It is the preferred ARB in hypertensive patients with gout. 7. Olmesartan and sprue-like enteropathy. Chronic diarrhea, weight loss, villus atrophy on biopsy. Symptoms resolve with discontinuation. Final recap. ARBs block the AT1 receptor, preventing angiotensin II from causing vasoconstriction, aldosterone release, and sodium and water retention. Unlike ACE inhibitors, ARBs do not affect bradykinin, which is why they have a much lower incidence of cough and angioedema. The RAAS-related side effects they share with ACE inhibitors, hypotension, hyperkalemia, acute kidney injury, all trace directly back to blocking that angiotensin II signal. The mechanism always dictates the side effects. That's ARBs. You now know the mechanism, side effects, and some testable fun facts. As always, linked in the description is a set of practice questions that should really help applying the material. Half of studying is practicing. Any questions? Leave a comment down below. Next up, we're working on calcium channel blockers, a cornerstone in cardiovascular pharmacology. So make sure you're subscribed and don't miss it. See you in the next one.